Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone, this is Hussein Ziada, Assistant Professor of Ophthalmology at Al-Azhar University, Cairo, Egypt. And the lecture today is about the errors of refraction, one of the main subjects of ophthalmology, the optical phenomena of the eye and how to correct its errors. So, this is the normal eye, which has at the same time the normal vision, where the normal curvature of the cornea, the lens, and then the parallel rays enter the eye, and then they are collected together to form a sharp focus onto the fovea, which is the central part of the macula, and it is a fixation on the central part of the visual axis, which is responsible for the receiving the light rays coming from the objects you want to see, then transforms these light rays from thermal energy to electrical energy, passing through the visual pathway back to the retina, back to the brain and the visual centers to be explained as an image. So this is the story of vision. The Ametropia. The Ametropia is a term defined as the normal the vision status. Ametropia can be defined as a state of refraction when the parallel rays of light coming from infinity are focused at the sensitive layer of the retina, with the accommodation being at rest. As I mentioned before in the previous photo, the parallel rays, without any action from the eye or inside the eye, without any accommodation events, the parallel rays come to a sharp focus onto the macula, or the fovea, which is the center of the macula, without accommodation, without any aids from the inside or the outside of the eye. So this status is called Ametropia, where there is no errors of refraction. It's called Ametropia, the normal state of refraction, forming the normal vision. Diopter is the standard unit to express the refractive power of optical lenses. This is an introduction for some terms which may be used during the presentation regarding the errors of refraction. So the diopter is the standard unit to express the refractive power of optical lenses. Whatever the sign, a myopic, hyperopic, astigmatic, is called minus 3 diopters, plus 3 diopters, and so. Reciprocal of the distance. Diopter is a calculation of reciprocal of the distance in meters between a lens and its focus, or its focal length. So if the focal length of a lens is 0.20 meter, which is 20 centimeters, its power in diopters is 5 diopter by this equation. What's the accommodation? Accommodation is the ability of the eye to change the refraction of light as it passes through the eye by changing the curvature of the lens of the eye. So simply, the accommodation is an involuntary reflex from inside of the eye. It's stimulated when the eye experiences a blurred vision. So the eye reflexively tries to correct this blurring by a series of events. So the accommodation enables the eye to change the refraction, the state of refraction of this eye, trying to bring the focus sharply onto the retina and correct this blurring. Stimulus blurred retinal image, as I said, contraction of the ciliary muscles, relaxation of the zonular fibers, thickening of the lens, so leads to increased refractive power of the eye. So the accommodation, in its simple definition, it's an act to increase the power of the eye, to increase the refractive power, or increase the refraction of the eye. So it will be helpful when you have an eye of when you have the eye status with less refractive power. So you will need an accommodation to increase the power of the eye. Before going to the types of error refraction, we have to show first the lens system, or actually the refractive system of the eye. You have to know that the eye has many surfaces which are responsible for the refraction of the eye and formation of the image. So there are the corneal surfaces and the lens surfaces. And in between the corneal lens, between the lens and the retina, we have a media. And this media with almost no impact on the refraction of the eye. So the responsible surfaces by the refraction for the refraction of the light is the corneal surface, which is the main surface responsible for refraction. And then the lens. We have two surfaces for the cornea, anterior surface of the cornea and the posterior surface of the cornea, and both of them are convex. But the main surface is the anterior surface of the cornea. The effect of the posterior surface of the cornea on the refraction is almost neglected. It's insignificant. So it's not calculated in the refraction process. About the lens system, the lens is composed of four refractive interfaces. The interface between the air and the anterior surface of the cornea, this is the path of the light rays from the outside to the inside. They are passing through four refractive interfaces. The interface between the air and the anterior surface of the cornea, the interface between the posterior surface of the cornea and the aqueous humor, the interface between the aqueous humor and the anterior surface of the lens of the eye, and the interface between the posterior surface of the eye and the vitreous humor. At these four surfaces, the refraction happens. So the anterior surface of the cornea is a major refractive surface of the eye. Effect of posterior chamber. The posterior chamber almost has no effect, but just justifying the light rays. This happens by or through the action of the pupil. When the pupil constricts, it decreases the light rays coming from the peripheral and the mid-peripheral parts of the lens and the cornea. So the pupil allows the central part of the light rays to enter inside the eye. So they are passing through the central part of the cornea and central part of the lens when the refraction is the least. So there is no diffraction, and there is a lot of the light aberrations and light myth passes. So it helps, the pupil construction helps the defining and sharpening of the focus and helping a better and clearer vision. After mentioning everything about the Ametropia and the physiological processes inside the eye, which is the accommodation, the interfaces, and the refractive surfaces of the eye. As I mentioned, they are the corneal and lens surfaces, but the main is a corneal surface. So we are gonna show the ametropia, causes and types. Ametropia is a state of refraction when the parallel rays of the light coming from infinity are focused either in front or behind the sensitive layer of the retina. We said that the ametropia is the normal vision. The light rays come to sharp focus on onto the macula or onto the sensitive part of the retina. But ametropia is defined as a disorder of this process when the focus comes to a point in front or behind the sensitive part of the retina. As you see, the refractive errors may be hyperopia, which is farsightedness, myopia, also called nearsightedness, axial myopia. It's caused by abnormality in the length of the eye, refractive ametropia, which is caused by abnormality in the refractive power of the cornea or the lens with the normal axial length of the eye. This is related to the hyperopia or myopia. So the hyperopia or myopia could be axial or refractive. Astigmatism means unequal refracting power of the lens in different meridians. This happens when the corneal surface has a different axis or different meridian. So the refraction through the main meridia or the main curvature lines of the cornea is different. So the refraction from one meridian is different than the other, so we have a lot of images, not a sharp one. Presbyopia is defined as a decreased accommodation with aging. So the eye is unable to see the near objects. This happens after the age of 40. When the patient approaches or comes to the age of 40, he starts to find a difficulty in reading the near objects or seeing the near objects. So it's called presbyopia. It's age-related changes. It's not pathological changes. Aphakia means absence of the crystalline lens from the media, from the visual axis, maybe inside of the eye, but out of the visual axis or completely absent. Anisometropia means inequality in the refractive power of the two eyes. The two eyes has unequal errors of refraction, or one of the eye has an error while the other eye is completely normal. So the difference between both eyes is called anisometropia. Etiology of the refractive errors may be axial or curvature, as I mentioned, or index, related to the nature of the lens, nucleus, and contents. So the index means changes in the nature of the media through which the light rays pass, so may lead to this error refraction. Positional hypermetropia or absence of crystalline lens, which is aphakia. This is the etiology of the hypermetropia. Symptoms and signs of the refractive errors in general. There is cardinal signs, which is decreased visual acuity, is a common sign. The patient complains that the objects could be near objects or far objects are not clear, and he is trying to see this object clearly, but he cannot. So the cardinal sign is the decreased visual acuity. Athenopia, weakness, or easy fatigability of the eyes. Headache discomfort should be related to the use of the eyes and relieved when the eyes are not in use. Every day we have a lot of patients coming to our clinics with headache, and they may be sent from other consultant to you to check for the eyes, which could be a cause for this headache. So the most important question, the timing of headache. When you have this headache, if this headache is related to the use of the eye, concentration, the reading, working in front of the computer for a longer time, yes, the headache could be from the eye. But if the eye is at rest, if this patient wakes up at the morning with this headache, mostly this headache is not related to the eye, or actually not related to the refractive errors. Let's go showing the hypermetropia, which is one of the most important refractive errors. The hypermetropia or hyperopia is defined as the parallel rays of the light coming from infinity are focused behind the retina. It's theoretically with accommodation being at rest, but the accommodation, if the accommodation active, the hyperopia may be corrected. Thus, the posterior focal point is behind the retina, receives a blurred image. As I said, it's also called hyperopia. The accommodation suspended, so the better rays of light are intercepted by the retina or behind the retina. Usually the two eyeball that's too short, it's axial myopia, axial hyperopia, or the lens system that's too weak, it's called refractive hyperopia. There is the refractive power of the lens and the cornea are lesser than needed or than normal, so the light rays diverge to form a focus behind the retina. This figure shows what I said in the previous slides. On 25 centimeters, the near objects come to focus behind the retina. Image is formed behind the retina is blurred because it's out of the sensitive part of the retina. So the eye lens has a larger focal length and less converging power. And this is a diagrammatic photo showing what could happen with a patient with hyperopia. He can see the far objects hazy, but much clearer than the near objects. The near objects are so blurry, but the far objects are somewhat clearer, and as they are away, the farthest, the image, the clearest it will be, because the relaxation of the accommodation and also the amount of the accommodation needed to see this object will be lesser, so that the eye can correct this error. But the nearer the object, the more blurring, because of the power of the accommodation which is available in this eye are not enough to correct this error. Signs and symptoms of hyperopia: asymptomatic, athenopic symptoms, defective vision, yes, size of the eyeball, it will be small in axial hyperopia measured by the P scan. Anterior chamber will be smaller or shallower comparatively to the normal persons. Simply, the treatment of hyperopia is aiding of the eye to converge the light. So the convex lens will be the treatment for hyperopia, because the convex lens focuses the light rays. it will be correct the hyperopia by increasing the refractive power of the eye and changing the focal length and the focus to come onto the retina. Aphakia is absence of the crystalline lens, so it's a major form of hyperopia where there is no lens, there is no converging power of the eye because of the absence of the lens and absence of two surfaces refracting or converging the lights. Aphakia is the absence of crystalline lens from the visual axis. It could be displaced, not in line with the visual axis, or completely absent, as I mentioned before. Because of surgical removal, as in case of congenital cataract, in the first year of life, we may go for the cataract surgery in these babies to remove the lens without implanting an artificial lens. So the patient is left aphakic for a time. So the surgical removal or secondary to trauma with the lens displacement. So this aphakia will leave the eye with very low power of refraction, and it's a major form of hypermetropia. It leads to severe hyperopia and loss of accommodation, as I said. So the chief symptom of aphakia is decreased vision for both near and far. No symptoms of the ocular discomfort since accommodation is not possible. As shown this figure on the right and the left down, there is displacement of the crystalline lens, and it's called subluxated lens. So in Marfan syndrome or homocystinuria, there is subluxation of the lens, and in severe forms of the subluxation, the visual axis will be aphakic. The lens will be out of the visual axis, so this patient will be aphakic. Diagnosis: loss of the reflected image from the surface of the lens. When we back to the Purkinje image, when a lighted candle put in front of the eye, you will see pictures for this candle on the cornea, and on the lens you will see around 3 to 4 images. One of the anterior surface of the cornea, and the one on the posterior surface of the cornea, one of the anterior surface of the lens, and one on the posterior surface of the lens. So you will have 4 images, but the most apparent are three images for this object, so it's called Purkinje images. In case of the aphakia, you will find just the corneal surface, one Purkinje image for this candle, because the lens is not present, so you will lose 2 images. The first sign, or the simple sign in diagnosis, loss of reflected image for the surface of the lens. Excessive movement of the iris because of the loss of support of the anterior lens of capsule is called iridodonesis or tremulous iris. The aphakia is corrected by means of the intraocular lens, but we can start, especially in the babies or infants who were undergone congenital cataract surgery with just lensectomy without implantation of the IL. They may be corrected with the contact lenses or with spectacle lenses, the thick glasses, to correct this large degree of hyperopia. So it will be corrected with contact lenses, glasses, and then implantation of artificial intracorneal lens, which is placed immediately behind the iris after an extracapsular cataract extraction or inside the bag if you have a good bag. an additional convex lens is required for near work because loss of the accommodation. So up is the eye is aphakic. After implantation of the intraocular lens, the eye is phakic but artificial lens, so it's called pseudo-phakic. Phakic means crystalline lens. Artificial lens is called pseudo-phakic. But it will correct the vision for the far and the intermediate distances, but this patient will need an additional correcting glasses for the near vision. So after covering the hyperopia and the aphakia, we are gonna talk about the myopia. Myopia is the short-sightedness. The patient can see the near objects, but the far objects are hazy and blurry. So myopia is the optical condition in which rays of light entering the eye parallel to the visual axis come to a focus in front of the retina, because the refracting power of the eye is more than normal. So the focus comes in front, does not reach to the retina, but comes in front of the retina. So the aim of this, the meaning of this myopia, that the eye is more powerful, is powerful than needed. So we are, to correct it, we have to weaken it to help to help the focus to come onto the retina. So usually the myopia are the two large eyeball, which is called the axial myopia, with the axial length of the eye is more than normal. A lens system that is too strong, it's called curvature or refractive myopia. The refracting surfaces of the eye, either the cornea or the lens, are more than normal, so the power is higher than normal. As you see, the picture above shows how the lamp image comes to a part in the vitreous in front of the retina, so it's hazy, and down the face is clear, but the trees away are so fuzzy and hazy. This is showing how the myopic person sees. Types of myopia. There are many types of myopia. The physiologic myopia, pathologic, degenerative myopia, and lenticular myopia. Physiological myopia, either axial or refractive. Axial related to the axial length of the eye, it's taller or longer. So this is called axial myopia. If the corneal surface and the lens surfaces are powerful, so it's called refractive myopia. An adequate correlation of the refractive power of the corneal lens with the length of the globe is called axial and refractive. At the onset of this physiological myopia, between 5 to 10 years up to 25 years old, gradually increases until 18 years when the eye is fully grown. So the physiological myopia is a benign one, and its progression is very slow and very limited, and the stability of this eye will be around the age of 18. Seldom exceeds 6 diopters. So the physiological myopia will be less than 6 diopters. Beyond 6 diopters, we'll go to the pathological myopia, which is called degenerative myopia. The pathological or degenerative myopia is always axial because it's related to stretching of the eye, or the axial length of the eye is excessive because of overgrowth of the posterior 2/3 of the globe, and it may be accompanied with posterior pole abnormalities like posterior staphyloma, and also stretching of the retinal fibers and choroidal fibers with a degeneration of the choroid and retina. It's called myopic chorioretinal degeneration. It commonly begins as a physiologic myopia, exceeds 6 diopters. The eye continues to enlarge rather than stabilizing when the globe is adult size, so maybe beyond the age of 20 to stabilize. Lenticular myopia, it's mainly refractive due to increasing refractive power of the crystalline lens related to the anterior segment. Occurs in uncontrolled diabetes mellitus, nuclear sclerosis, aging, drugs, hydralazine, chlorothalidone, and phenothiazines. So these drugs may lead to increasing the reflective power of the lens. It's called refractive or index myopia due to changes of the lens contents, not the lens shape. So treatment of myopia will be by decreasing the power of the eye through the concave lens, which diverge. The concave lenses diverge the light rays, so helping them to come into a focus back on the retina and corrects this error. This is the opposite to the hyperopia. The convex lens is converging the light rays, while the concave lens is diverging the light rays, according to the principle of H error. So we have mentioned the hyperopia, myopia, and now we are gonna mention the third type of refractive errors, which is the astigmatism. Astigmatism is an optical condition in which the refracting power of the lens or an eye is not the same in all meridians. If the corneal plane is not regular, is not equal in the vertical and the horizontal meridia, so the refraction is different in the different meridia, and so the image will be and so the focus will not be a sharp point, will be a multiple points together. So the image will be fuzzy, will be hazy, and will be maybe distorted, maybe oblique, according to the distribution of the meridian. This may happen on the surface of the cornea or on the surface of the lens when the lens is unequal or tilted, or some problem with the lens. Some problem with the lens may lead to obliquity, maybe to different stretching, due to subluxation, whatever the cause. This will lead to this abnormal and unequal refraction and the astigmatism. This most often results from too great a curvature of the cornea in one plane of the eye. So the parallel rays form an object do not fall on a single point. Symptoms of astigmatism: a distinct retinal image cannot form. There is no sharp image. The changes in accommodation cause symptoms. Severe astigmatism may cause the optic disc to appear oval rather than nearly circular because the distorted image. So the tilted disc may be a sign for the corneal astigmatism or lens astigmatism. Types of astigmatism: regular, irregular, lenticular, curvaitural, positional, and retinal. The most common is the corneal astigmatism, which is regular or irregular. Regular meridians of the minimal and the maximal refraction are at right angles to each other. Irregular meridians are not at right angles to each other. But actually, the regular astigmatism means that the corneal surface meridia are apparently arranged in a straight and regular manner, while the irregular astigmatism, the meridian, the main meridia, the vertical and the horizontal meridia are not related to each other at all, and the curvature is not complete on the corneal surface. Because of the curvature, the media or the radial, the curvature of the cornea, I want to simplify it because it's somewhat complicated, but so I'd like to simplify it for you. Normally, you will find that the superior part of the cornea and the inferior part of the cornea, in the vertical and the horizontal meridian are related to each other. The meridian is complete, superior and inferior. But the irregular astigmatism, you may find that the superior part of the meridian is not related to the inferior part of the meridian, which is called the poti. So the poti may be regular poti, symmetrical or asymmetrical, maybe one part of the poti, but the other is absent, and so. So the lenticular meridian, the lenticular astigmatism is rare. But it's present, but it's not common like the corneal one. Curvature, abnormalities of the curvature of the lens, positional, tilting, or oblique placement of the lens. This is a lenticular lens. Retinal astigmatism is also not common, but present especially in the posterior pole changes with high myopic patients due to posterior staphyloma, or oblique placement of the macula due to other causes, compressing mass or something compressing on the back of the eye. So the regular astigmatism, in which the cornea has two different radii of curvature at right angles to each other. Biologic variant due to weight of upper eyelid resting on the eyeball, surgical incisions into the cornea, trauma, scarring of cornea, tumors of the eyelid, and lesion. All of them may cause the astigmatism. While the irregular astigmatism, the cornea has three or more different curvatures, causes corneal scarring, keratoconus, variations in radii of curvature of the crystalline lens, lenticular astigmatism, minor degrees of astigmatism, as I said. Simply types of the corneal astigmatism. As I said, the corneal astigmatism is the main cause of astigmatism. So the types of corneal astigmatism is regular. The main corneal media are just two, the vertical and horizontal, the steepest and flattest K or axes. Irregular, many media on surface but not related to each other. With a rule, astigmatism, the steepest axis is the vertical one. Against the rule, the steepest axis is horizontal. Symmetrical main axes are perpendicular to each other. You will find that the steepest and the flattest media are in an right angle at 90 and 180 degrees. While the oblique astigmatism, the main axes are not perpendicular. Maybe the steepest may be on the angle 45, and the flat will be on angle of 135 degrees. This is the image the patient will, with astigmatism may see. Blurring, hazy for far and for near. It is distorted with shadows, with halos and adds. Keratoconus is one of the common forms of irregular astigmatism of the cornea. So the cornea in the normal, it's regular and smooth, while the cornea becomes cone-shaped with the apex of the cone below and nasal to the corneal center in cases of keratoconus. How to correct the astigmatism? The cornea, as I said, with two different curvatures. So it neutralized by cylindrical lenses, which allows a line of focus to form, which parallel which parallels the axis of the lens. This means that the lens will correct the different curvature, one steep and one flat. So the lens will correct either to flatten the steep or to steepen the flat to make both axes or two curvatures equal to each other, so that will form a sharp image for the object. Hard contact lenses may be used to correct the irregular astigmatism, but the soft contact lenses and the spectacle lenses will be used to correct the regular astigmatism. In keratoconus, corneal transplant should be considered in the very advanced cases. One of the exceptional type of the refractive errors is anisometropia. Anisometropia is a condition. Anisometropia as a term is called anisometropia. Which means not, iso means similar, metropia, refraction. So anisometropia means unequal refraction of both eyes. So it's a condition in which the refractive error of each eye is different, at least more than 2 diopters. There are refractive errors of both eyes with more than 2 diopters difference, or one eye is sound with no errors and the other eye with a refractive error more than 2 diopters. Neutralized by prescribing the appropriate prism and reading segment using separate lenses from near and far vision if they are phakic. But if they are phakic, I will correct this problem with the spectacle lenses if tolerable, especially in the axial errors. But if not working, you will prescribe a contact lens to correct this and make the errors closer to each other. Otherwise, we will consider if the spectacles and the contact lenses are not suitable, you will consider the surgical correction for the eye with the higher error to make it closer to the other eye. And this is to avoid the amblyopia and laziness of the eye. So finally, we will move to the correction of the refractive errors, which will be first. The first line is the glasses, the spectacles, by use of lenses. The hyperopia will be corrected with the glasses or spectacle lenses of plus sign, which is convex lenses. Myopia will be corrected with the spectacle concave lenses. Correction of presbyopia. Sorry, before leaving this slide, it's called spherical lenses, convex spherical and concave spherical lenses. The word spherical lenses means that the all parts of the lens are with the same power, are equal. There is no part higher in refraction than the other part. It's called spherical lenses. While the different parts with different refractive powers in the cylindrical lenses, which will correct the astigmatism. Presbyopia, I mentioned before the presbyopia and defined it as the inability, its inability of the person to see the near objects. Because of age, there is no errors. This presbyopia treated by convex lenses added to the distance correction. This patient, if this patient, if there is an error, a refractive error for the distance, this patient will use the distance, this correction for the distance, and then there is an add. A correcting convex lens will be added to the distance correction. The weakest possible convex lenses to permit individual to carry on different tasks. Maybe bought as a separate glasses, glasses for distant vision and the other one for near vision, or maybe made in one glasses by the bifocal lenses or trifocal lenses or multifocal lenses. Also, the correction could be by the contact lenses, the soft contact lenses for the all types of error and the hard contact lenses for the irregular astigmatism, as in case of corneal scarring and keratoconus. With prescription of the contact lens should be under supervision of the medical personnel for the ophthalmologist. It's not allowed to be prescribed by the optometrist in the optical shops or by other means, because the eye status should be checked first for the suitability for wearing the contact lens. Then, according to a table, the power will be prescribed. Finally, the surgical correction of the refractive errors. Surgical procedures for the correction of the refractive errors will be LASIK, PRK, LASIK laser in situ keratomiliosis, PRK, photorefractive keratectomy. The difference between both, that the LASIK, there is a flap creation first before application of the laser, the excimer laser, and the PRK without flap, but just removal of the epithelium, which will heal after the operation within the first 5 days. So they are very, very effective and simple and safe procedures to correct. Radial keratotomy, radial keratotomy and INTACS for cases of corneal astigmatism, as in keratoconus. Phakic intraocular lens implants inside of the eye if the corneal procedure or laser-based procedures are not suitable for this patient. Advantages of the surgical corrections. In case of high refractive errors, the error may be brought down to a more manageable level so that it can be corrected by other means. No need for glasses, contact lenses, no maximum wearing time. Disadvantages. All surgical procedures have a statistical failure rate which may range from improper correction to loss of the eye. It's truly reported, even if it's safe, but there is a percentage all over the world with a complication which may lead to this disabling of the eye. Costly instrumentation and surgery not freely available. Stringent case selection, should be counseled and should be strict. Radial keratotomy, it's an old technique. It's not nowadays. It's not used nowadays. More commonly performed before the use of excimer laser, surgical procedure used to decrease myopia by 2 to 6 diopters by corneal incision, which will heal with the scar formation. This scar will flatten the center of the cornea, decreasing the power of the eye, acting as a concave lens. Procedure less predictable and less stable than laser vision correction. PRK, using the excimer laser on the surface of the cornea after removal of the epithelium. The laser will be calculated according to the error to be corrected. But discomfort is greater than LASIK because of the absence of flap. Range of refractive errors, which can be corrected by the PRK, is also not as wide as that of LASIK. Yes, up to -5 diopters corrected, but by LASIK up to -8 if the cornea thickness allows. LASIK, the same surgical procedure intended to reduce person's dependency on glasses. Most commonly, the same for the myopia, nowadays for the hyperopia and also astigmatism. Permanently changes the shape of the cornea, but there is a flap creation of 100 or 110, 120 micron thickness. It's created, lifted, and then the laser applied, and then the flap will be replaced again to its position. this will decrease the pain and discomfort and will speed the recovery with a good results. It's ambulatory procedure. Phakic intraocular lens, as I said, if the laser based on the corneal surface is not available or not suitable for this patient, the high errors may be corrected with implantation of intracorneal lens on top, in front of the crystalline lens, between the iris and in front of the crystalline lens without removal of the crystalline lens. It's called phakic IOLs. IOL inside the phakic eye. The phakic lens is inserted and through incision in the place just in front of the, or just behind the iris, yes. In front of the iris in one type, but it's not commonly used nowadays, but the most common nowadays is in the ICL, implantable contact lens, just behind the iris. Finally, the INTACS. INTACS, it's a polyacrylic ring segments from polymer is made, placed under the outer edge of the cornea through tunnels, which may be formed manually or by the femtolaser, which is commonly used nowadays to form the tunnel to be more precise and muchly safer. So this tunnel will be formed by this laser, and then the intracorneal ring is implanted in this tunnel to flatten the cornea and to decrease the irregularities of the corneal surface. So advantages of the INTACS or the intracorneal ring segments is the reversibility. You can remove it. Tissue is not removed and the eye is not structurally weakened. Delivers an excellent quality of vision in most of cases, yes. This advantage is only approved for low levels of myopia and does not correct astigmatism. Actually, this fact may be changed nowadays, but I'm not. I don't like to make it difficult and to make it complicated and sophisticated for your level, but actually it nowadays may correct the high degrees of astigmatism. But on your level, we should know that this is it's called as a stand or something supporting the cornea to flatten the surface, correcting some degrees of the myopia, and at the same time may flatten the cone, and decreasing the astigmatism and providing a better vision for this patient. Thank you for your attention.